All right, here we go. So thank you for attending today's, I guess we call it extra seminar. The purpose of today's seminar is to go over the data and the data sets that we are using. We're going to have four different groups presenting. First presenting today will be Lucas Tramontosi. Lucas is the Chief Technology Officer of the Louisiana Department of Health and Hospitals. Lucas will go over some sort of general overview of what we're trying to accomplish, both with today's meeting and CajunCodeFest in general. I also believe that we will have HealthVault and Microsoft joining us probably later during the meeting. If not, I will take that aspect of it, but Microsoft HealthVault is one of the ways that we will be using to push out data and using their toolkits to create applications if that's what the developers and coders so choose. We also have two other ways through a partner of ours called Box.com, where we're putting up a SQL backup database as well as some flat files to people to access. And then the final way is we're going to have Reza Jelva talk today about the API, the open source API that he's building, and will be available for CajunCodeFest. That will be another way for us to connect to, or for the coders to connect to the data. So I'm going to turn this over to Lucas here, and I'm going to bring up your PowerPoint, Lucas, and launch it and get you started.
Great, thank you, Ian. Fantastic. Let's go to the next slide. Well, welcome, coders. We're excited to have you participate in this year's CajunCodeFest. This theme is Own Your Own Health. I'm going to take the next 30 minutes or so to review with you not only the purpose of the theme, but also to really do a deep dive into the data elements that you can expect to see next week leading up to the CodeFest, so then that way ultimately you can deliver and be successful in programming innovative apps to help engage consumers in owning their own health. Next slide, please. Currently in the United States, we have been spending large investments in integrating our healthcare delivery system. Today's reality is that technological innovation can vastly alter process, cost, and outcomes. And we know that healthcare traditionally is far behind other industries for leveraging IT. The problem is in all of these investments that it's great, like this position on the screen is now we're able to leverage things like iPads, mobile devices, and other such things to communicate with the patients. But go ahead and click, Ian. What this has essentially done is disconnected the physician from the patient in their own experience. Let's take the use case, go ahead and click, Ian, of my wife. When it was time to deliver the baby, I had to call for medical transportation, who took my wife then to the hospital. Upon receiving my wife in the ER, they did two things. They first called the health plans to make sure that I could pay for it, and then they contacted the physician who met my wife in the ER, decided to run some labs to make sure she was ready for the C-section, and then decided it was time to go to the pharmacy to order medication to knock her out for the delivery. We had a healthy twin girls. The hospital and the physicians then needed to report to the public health agencies. I then needed to contact my employer to let them know that my insurance was changed. They had already spoken to my health plan, and then all of my providers started sending bills to the health plans. Afterwards, I had to go to the clinic with my wife to get my babies checked out, which then caused further additions and communications. And then ultimately, my wife was informed by a doctor that she needed to exercise and do more, which meant that we had to buy some home health fitness devices so then that way we could track her health and wellness moving forward. As you can see in this diagram, there are a lot of touch points. This is all done electronically, leveraging technology, but ultimately what happened is that the technology now is an end instead of a means to improve healthcare. We're generating more data and getting less knowledge from it. Our patients are completely disconnected from their own health, and ultimately we can't say that personal responsibility on the patient has failed. What we have done is we failed to make it easier for our patients to be completely engaged and empowered to own their own health. Next slide, please. So essentially, I like to refer to a quote that ePatient Dave, who is a cancer survivor, a blogger, and an evangelist for patient engagement, had said to us 3 years ago, challenge the medical community to give me my damn data. And so from that, through the leadership of the VA, they created something called the Blue Button Initiative, in which they created a mechanism for easy, secure access for an individual to their own data. They're now able to view and download that data. The data is machine readable, and there are technical guidelines in which developers can build on. However, go ahead and click. This is just the first step in making a difference in our patients. That there is the basic principle of patients are not a third-person word. All of our time will come where we will be patients, where we will need to own and engage in that healthcare delivery model. And that it's the right of desperate people to try to save themselves with the best information available. We have to know what our options are, and we have the right to pick up our data and pursue options elsewhere. And so ultimately, we need to get to the point of an engaged patient is the empowered patient. And it's not good enough to throw data at people anymore, that it's not going to solve the problem. The challenge to you coders is to take that data, envision the person at the center of the communication, and make that data meaningful, make it relevant, make it fun, make it a game, make it consumable, make it contextual, make it actionable, and make it thought-provoking. And so that, coders, is your challenge for CajunCodeFest 2013. We're going to provide you a vast and impressive data set in which you can program on. Your challenge is to create applications that engage consumers in their own healthcare to empower them to make meaningful decisions. So let's get into it. What data is available for CajunCodeFest? Go ahead, next slide, please. And let's go to the next slide as well. So quick overview. We are going to be providing you with 200,000 unique individuals' medical information. There are over 6.6 million Medicaid claims, over 8 million Medicaid prescriptions, over 4 million immunization records, with roughly 30,000 providers engaged in the health of these individuals during the course of several years. I'd like to also mention and recognize our partner, Privacy Analytics, who helped assist the department in appropriate de-identification and masking, so then that way we can provide as real data as possible to you to make meaningful applications. Next slide, please. Next slide, please. Just a quick overview. For the 200,000 patients, we wanted to help you visualize where they are in the state as well as where our providers are located. This is a statistically representative sample and distribution of both providers and patients. As you'll see on the map on the left, our patients are spread across the state, both urban and rural communities. Our providers, likewise, are concentrated predominantly in our metropolitan areas with fewer providers in our rural areas. These are real-world examples of what faces our medical community in Louisiana today. Next slide. You can go on CajunCodeFest.org to find the data dictionary, which I will speak to during this presentation. It is a complete dictionary that includes ERD documents, the tables, as well as reference materials to help you navigate all of the elements that will be discussed. The data set consists of 6 tables: demographics related to patients, eligibility, which shows the period in time that these patients are covered by Medicaid, a provider file, their claims file, prescription file, and then the immunization data set. Next slide, please. Here you'll see the entity relationship model for the database. And this has been optimized for performance. And you'll see how these elements are connected with several keys, the patient ID being the most important, one of the most important keys across the tables, as well as provider ID. Next slide, please. In the demographics table, you will find all information relating to the patient. There's the unique identifier, again, that's been masked appropriately to 40 digits. The Social Security number, masked and de-identified. The patient's first and last name, also masked. Their addresses, masked, with the date of birth and gender. You'll notice on the right-hand column that we're providing you examples of what that data would look like as you prepare your own data sets appropriately. Next slide. And there are 200,000 patients, unique individuals, for this competition. This slide shows the age distribution. Like many states, as a Medicaid agency, we tend to treat the younger individuals as they get, are covered from birth until about 18, and then those numbers dwindle as they get older. Next slide, please. The eligibility table describes the payer coverage for that individual. This is typically what one would find in a data set following the standards of the Blue Button Initiative. The link is provided below that you can reference as well. To simplify the competition, we have set all patients' eligibility period from January to December for 2011, and that the payer type is set to Medicaid only, and there are no sub-programs within Medicaid. And the intent of this was to simplify this particular table so that way you could focus on other more relevant information. Next slide, please. The provider file includes all providers that have either had a claim or provided a service to the 200,000 individuals in this data set. You will find a unique identifier, provider ID, that will help join the provider to the various tables in the database. The MPI is a National Provider Identifier, which is a national number that you can use to reference other publicly available data sets. For example, if you wanted to bring in information about any actions taken against the physician by a licensing board, you can match that on the National Provider Identifier. NPIs are provided for all but 3,200 providers. Those providers who don't have an NPI are not licensed by boards for particular services. That's not to suggest that physicians aren't licensed. All physicians are licensed. But there are certain provider types that are not mandated to have an MPI, and so we do not have those. The provider type will describe what type of provider they are, whether it's a physician, a hospital, a facility, a home health agency, a nurse, whatever it might be, with appropriate descriptions, and also you'll find the name, address, state, and zip. I want to point out that you'll notice there are two addresses, provider addresses. The null and then the provider address 2. Because of the way the information is structured, rule of thumb is that the second address will be the city for the provider. That's not always the case, but I want to make you aware that you will find city and address 2. Part of this exercise, and something that ePatient Dave regularly preaches, is the only way to get good data is to make it available and receive comment, and so we are open to your comment and experience in using this. Next slide, please. Next slide, please.
I'm sorry, Lucas, my screen seems frozen. Give me a second.
Okay, sure. Well, then I will just point out that, again, we have about 30,000 providers in this data set for you to use in your application development. This is just a listing of the top 20 provider types, again, ranging from physicians to those physicians who only prescribe medication, to pharmacies, to dentists, to certified registered nurses, hospitals, durable medical equipment, personal care attendants, etc. In the data dictionary, you'll see a complete listing of all provider types. You will notice that physicians make up a majority of those who are submitting claims on behalf of an individual. Next slide, please. The claims file. The claims file contains roughly 6.6 million records, and the way that this is broken down is a claim identifier, the patient ID, the claim type and description, the procedure codes, which are going to be CPT and HCPCS codes, with their descriptions. There are 2 diagnosis codes submitted per claim. which will be ICD-9 codes, the provider identifier, the charged amount, the paid amount, and the date of service. A couple of things to note. The claim ID is not a unique identifier within the table. Multiple claims can be submitted for the same ID. For example, if a patient receives multiple services under one visit, that claim may be submitted 2 or 3 times. As such, the patient identifier is also not unique. Please refer back to the ERD. As I mentioned, CPT codes are used for under the procedures. For inpatient hospital stays, there are no procedure codes associated with that visit. The last thing to note, please, the charged amount is a number that is a general rule of thumb, but is not typically used for any actuarial work in the healthcare industry. The paid amount is the amount that Medicaid has paid. The charged amount is what amount will come through the bill, but that does not reflect the amount of money that Medicaid would pay for a given service, or that any individual would pay if they were to pay out of pocket. Claims are provided for 1 year worth of activity for these 200,000 individuals. Next slide, please. Oh, I'm sorry, before we do that, Dean, the other thing I would like to point out is that on the claim as well as for the prescription, you may see claims with a paid amount of $-. We have left the claims in there if there are any adjustments to the claims that are made. So, for example, if there's a dispute on the patient's behalf and a claim is reversed, then that claim would be identical minus the amount, which would show the negative number for that individual. And we've left that in there in the event anyone wanted to show claim activity and any adjustments made for a given patient. On this slide, the next 2 slides, we're going to go over just some general summaries for within the claim file. You'll notice on this slide that we have listed the number of claims by claim amount, the recipients, and the payments. Inpatient hospitals make up over $130 million for these 200,000 patients. The long-term care nursing homes make over $282,000 total paid by Medicaid. For the professional claim types, these are going to be the doctor's visits that occur during the year, and so they had the most number of claims, roughly 3.5 million claims submitted for these recipients. Again, a complete table is found within the data dictionary. Next slide, please. Here you'll see 2 tables. One table is for the top 20 procedure codes by payment, as well as the top 20 diagnosis codes by payment. The table on the left, again, refers to CPT codes, while the table on the right refers to ICD-9 codes. This is just for your information to know what the distribution is for patients. More information is found in the data dictionary. In this case, T1015 for clinical visit, an encounter that's all-inclusive. So for a total medical check, it was roughly 104,000 claims submitted, which is roughly 1.6% of the total claims. And that covered 30,000 individuals for roughly $12.5 million. On the diagnosis side, hypertension, not otherwise specified, was submitted the most for 20,000 individuals, roughly 10.6% of the population, for $34 million worth of claims. It's important to note that you do not have to limit yourself to using ICD-9s as the ultimate grouper. There are publicly available groupers to roll up to more meaningful categories than ICD-9s or CPTs, and you can find that on public websites listed in the subsequent slides. Next slide, please. The next table that's available to you are the Medicaid prescriptions. There are roughly 8.9 or 8.1 million prescriptions that were submitted that cover a 5-year period for the individuals. Here you'll have the prescription number, the patient identifier, the provider ID and prescriber ID, the national drug code, and the drug name associated with that NDC, the prescription quantity, strength, and dosage, as well as the date of service. The provider identifier is most likely the pharmacist who has provided the medication to the individual, while the prescriber, most often than not, is the physician who wrote the script and that was sent to the pharmacy. It's important to note that for quantity, strength, and dosage, quantity will typically refer to, in this example, the number of tablets given. So in this case, for this patient, 20 tablets of doxycycline was administered to the patient at a strength of 100 milligrams, and the dosage was in tablet form. And in the data dictionary, we'll show the various dosages that would be available in this data set. Next slide, please. For additional information on how this data would be available, please see the link that was on the slide previous. This current slide shows that the top 20 prescriptions by NDC, code and description. And in this case, hydrocodone was the most frequently prescribed medication. Again, for more meaningful aggregations, the NDCs can be aggregated at therapeutic class level, which is also a publicly available data set, so then that way like medications are grouped together for more meaningful information. Next slide, please. The last table that will be available to you are immunizations. All information in this table contains all immunizations over the lifetime of that recipient. The fields in this table are patient ID, the CVX code, which stands for vaccine administered, the CVX name associated with that code, a contraindication code and description, the lot number, the manufacturer name, the facility in which the vaccine was administered, the performer or clinician who administered that vaccine, the route in which the vaccine was given, the administration of the vaccine, and then the immunization date. And there are over 4 million immunizations administered to the 200,000 individuals. You'll notice here that there are many null counts for some of these fields. You must remember that the immunization registry is built on information that gets entered at the time of administration. Someone like myself who moved to Louisiana will not have all of their childhood immunization details, such as lot number or manufacturer name, because that was not present in my paper chart when I moved to Louisiana. Children who are immunized today will have a complete record, but for those, again, who are older and where there are paper charts, not all of that information was captured at the time and then entered into the Louisiana immunization registry. I'm proud to say that Louisiana has the best immunization registry in the country with the most robust information, and we're excited to make that available to you for this competition. Next slide, please. The following slide is going to give you the top 20 immunizations that occurred in this data set. You'll see many of them: MMR, DPAP, varicella, and Hep B for adolescents. All pertain mainly to childhood immunizations, but there are some for pneumococcal and others for the adults that we see year and year again. I would recommend that you can link this information to the CDC to leverage the appropriate schedules for individuals if you so choose in your app. Next slide, please. We've included some additional data sources for you to do some investigation prior to CajunCodeFest. You are by no means expected to go and incorporate any of these into your application. These are just guidelines for those who would like to do more research on the information that's available in the data sets. 59 codes are maintained by a committee including the CMS, the Centers for Disease Control and Prevention, and the National Center for Health Statistics. There are over 15,000 diagnosis and procedure codes, and by following that URL, you can have a complete listing of codes, as well as the UB04 and the HCPCS codes that are available as procedure codes in this data set. The FDA maintains the National Drug Code Directory. The FDA processes electronic submissions of registration and listing information and stores that data for drugs, and it's updated weekly by the NDC numbers. CMS maintains the National Provider ID Registry, which tracks all physicians, all licensed physicians in the country. This is part of the development for the National Plan and Provider Enumeration System, NPPES, and that there are additional resources on what other information is available if you know the physician's NPI. The next data set is the National Library of Medicine RX norm. This is a tool for supporting semantic and I'm sorry, just going back to the, this is a tool for supporting the semantic interoperation between drug terminologies and pharmacy knowledge-based systems produced and maintained by the Library of Medicine. The sixth data set, or the sixth data source, is the National Library of Medicine's Medline Plus Connect. Medline Plus Connect provides AHFS consumer medication information written especially for patients. This is where you might be able to find information on drug interactions as well as side effects associated with drugs that you might want to incorporate into your application. The last link is from the CDC from their immunization information systems, where you can find information such as vaccination schedules and immunization code sets. Next slide, please. That's a quick summary of the data sets themselves. Again, I encourage you to go to the CajunCodeFest.org website to download the complete data dictionary for additional information. Now I'd like to take a few minutes to discuss how this data is going to be made available to you. Next slide, please. Before we can even give you access to data, I must make you aware that you will be asked to sign a disclaimer and restriction of usage agreement. Essentially, we have made best efforts to de-identify and mask all data to protect our patients' privacy and confidentiality. As part of this competition, you agree that you will not make any effort to or attempt to re-identify any part of this data as to find the identity of the information of the individual whose data you will be using. You will not reproduce or duplicate, copy, sell, trade, or resell any content for any purpose. And you will not disclose the information in a manner which violates any federal, state, or local law or regulation. Next slide, please. So you'll have data in 4 ways. The first two will be available through a Box account. It's going to be a text-delimited flat file or a SQL backup that you can restore locally on your machine. As Cian had mentioned, for those that want to start building on a platform, HealthVault will make their API available for you to develop robust applications. And then Reza will speak to you about the OAuth API that you can incorporate into a pull mechanism. I'd like to take a few minutes just to explain how these files will look in Box if you so choose to download them. Cian, if you would mind bringing up the Box account. As Cian does that, you will be receiving an email early next week that will make the data available to you. When you log in, you will see a screen such as this, and you will enter the CajunCodeFest 2013 folder. Go ahead and double-click on that, Cian, please. In this folder, you'll find relevant content. You'll find a copy of this presentation. You'll find a copy of the database documentation that I reviewed previously. You'll find the flat file.zip. All 6 tables have been zipped up to compress it. You'll see that it's almost a half a gig of data, and so it's a very large file. You'll also then see the backup to the SQL table that you can restore locally. Cian, can you open up the folder flat files? I've created a folder that will show you what the zip file would look like once you open it up. You'll see the prescription table, the claims table, the immunization table, the demographic table, the eligibility table, and the provider table. These files are tab delimited and can be incorporated into any system that you so choose. And with that, I hand it over to you, Cian, for the next step. So that's how data will be available both as text delimited as well as SQL backup.
All right, thank you so much, Lucas. And right now what I'm going to do is turn it over to Reza Jelva. Reza is going to talk to you about the OAuth API, or the open API that we are in the process of creating for CajunCodeFest. Reza?
I'm Reza. I work with CBIT. We've been in the past few weeks in the process of creating an OAuth API. So the way you're going to be using it, if you're a developer and you've worked with other APIs before, is going to be very similar to the way you use the Google APIs. So you can log into your account and you will be able to create access tokens for your application, which will then allow you to make a client application which allows you to log in to a certain user by using their demographics, which is going to be the first name, the last name, and the birth date, and then allow you to securely retrieve data for that particular user. And if you want to think about it in a different term, it's going to be very much like if you're building a Facebook app, except that the Department of Health, or we, are actually going to be Facebook in this regard. We're going to provide a few libraries. We'll provide some code. You'll get sample code for a browser extension. You'll get a library for Ruby, and we'll provide documentation for .NET and Java developers. So it should be fairly straightforward and standardized to use.
Thank you so much, Reza. And so everybody knows that we will have this information up on the CajunCodeFest website. If you, and I'm going to move there just a second. And so if you go to the CajunCodeFest website, you go under About, and you hit Data, you will then see some of these documents that Reza talked about. This will also be where you can go to get the API, and today's presentation and some additional documentation will be displayed there as well. Let me say, do we have anybody from Microsoft Health Vault at this point in time on the call?
Hi, it's Phil Pennington.
Hey, Phil, how are you?
Good. Sorry to join late, traveling through delayed airport flights.
All right, Phil, so you know we are recording this presentation, and it's now your turn to describe what you're going to be doing with Microsoft and Health Vault.
Okay, sounds good. So we're building a utility that will front your database that you've provided and allow participants to pull from that database and load Health Vault records with that data. So it'll be using our test system, what we call Health Vault pre-production environment. We'll also provide some sample continuity of care documents that can be uploaded into those same accounts so that you have some staged data to work with your applications. We haven't yet completed the utility, but as soon as we do, I'll provide you information on that, and we'll work with you guys to post that.
All right, thank you so much, Phil. It's been a pleasure to work with the Microsoft team and with their Health Vault team in particular to help try to create a solution that allows everybody to have access to and the tools readily available in Health Vault.
Thank you. We're looking forward to participating with everyone and providing guidance on building solutions that integrate with Health Vault.
Wonderful. And we're just going through a little bit of the slides here, a little bit out of order. I always have to thank our sponsors for this year. We greatly appreciate all the folks that have donated of time, money, and services. And right now what I'd like to do is in our final few minutes open it up to any questions that the folks who've dialed in this afternoon may have for us regarding the data. Well, if there's no questions at this point in time, would any of the other presenters like to add anything before we wrap it up? All right, great. Thank you so much for today. Lucas, thank you for your presentation. Reza and Phil, thank you for your hard work. And we will see you starting next Wednesday at 6 o'clock to kick off CajunCodeFest. And I hope everybody has a great afternoon, and take care.